Hello, welcome to another episode of Let's Get Vaccinated, where each week we deliver a healthy shot of science and facts. We do two things on this show. We answer your questions about vaccines and the pandemic, and we all learn how to effectively communicate science, because sharing science is how we keep our community safe. In case you don't know me, my name is Dr. Neecey Hudson. I'm a computational biologist with a PhD in bioengineering, biostatistics, and bioinformatics. And I'm the chair and science director at Hood Medicine Initiative, which is a nonprofit guerrilla science communication and public health collective advocating for healthcare equity for all. And I'm excited to be your guest host tonight. We have a really great show today with a couple of amazing scientists. But first, let's start with a little bit of recent news. This week on Monday, the Pfizer vaccine was granted full FDA approval for people 16 and over. Hopefully this will lead to effective policies that mandate vaccination across several industries and begin containing the spread. It was reported also that the emergency use authorization for vaccines for children ages 5 to 11 might be delayed until early next year. So we'll have to watch that closely as our children continue their dangerous and premature return to the classroom. Also, the Delta variant continues to sweep the nation, but most of us are too busy partying to notice. I think we were all hoping for a hot vax summer, but it's actually Delta who's having the most summertime fun. We've seen music festivals and rallies all across the country. Though people are supposed to be vaccinated, are supposed to attend, that is also pretty much on the honor system like everything else. We need to press our leaders and local governments to enforce policies that support containment. And to do that, they need to follow the data. Data scientists and computational epidemiologists represent another group of unsung heroes of the pandemic. They've been our town criers, trying to steer us towards taking bold measures to combat this new COVID wave, although no one sadly is listening. So joining us today, we have two experts who've done some amazing work to build tools to help meet the challenges of the pandemic. I want to welcome Serina Chang to the program. She's a PhD candidate studying computer science with a focus on computational social science at Stanford University. She published a paper in Nature describing the mobility network model that she developed to help explain pandemic disparities and provide analytic tools for local municipalities for planning reopening strategies. So thank you for joining us, Serina.
Thank you so much for having me. I'm really excited to be here.
And we're also joined by Dr. Christin Glorioso, who's the head of research at the Data Informatics Center for Epidemiology for PathCheck Foundation, one of Hood Medicine's partners, actually, and who, after recently completing a postdoc at my alma mater, MIT, is starting her new appointment at UCSF this week. So congratulations and welcome.
Thank you so much.
How are you guys doing? How's it going? How's pandemic fatigue?
It's going okay. I think I am in a little bit of a better position than some people, I guess, because, you know, having been through the Delta wave in India with so many people at PathCheck, I was sort of expecting this to happen. So I don't have that letdown of I thought the pandemic was over and now it's not. So I've just kind of been in regular mode this whole time, like, wait for it.
Mm-hmm.
But
yeah.
What about you, Sarah?
You know, it's tiring. I've been working from home for, I guess, a year and a half now. I'm going into the third year of my PhD now. So this wasn't exactly the experience I was expecting, but that said, I think I feel very privileged, at least, to be doing work that I can do on a computer. It's not like I'm missing out by going into a lab or something. And so at least I can still move forward on my research in a meaningful way.
Mm-hmm. Christin, I wanted to start with you and have you explain some of the work you've been doing with PathCheck. How did you get started with the org?
Yeah, so great. I think should I do slides now or later? I think
Sure, if you're ready, yeah.
Yeah, I can just because I can tell you a little bit.
Yeah.
Okay, so this was not the first slide. So, because how I met Patrick was actually through the X Prize. So this is interesting. I was at MIT. Anyway, so I'm an MD PhD. I was at MIT modeling actually risk of Alzheimer's disease in these large human cohorts for genetic cohorts and transcriptomic cohorts. And then the pandemic hit, and as a computational biologist, I was sort of fascinated by the data, and I kind of couldn't help myself. So I started modeling the pandemic, sort of switching gears a little bit. I also am a nonprofit founder of an Academics for the Future of Science, which actually was an original March for Science partner back in the original March. So science communication is something that I've been doing for a long time, since 2013. So because, friends and family were at risk and there was so much misinformation in the news, I started both looking at the data and also talking to people online about, what was happening in the pandemic, all the way back to my first data-driven post, which was early March 2020, in which was basically something like, oh my God, New York, please don't go to work today. You're on the same trajectory as Italy. This is awful, and at the same time, the news is like not reporting any of that, right? So that's kind of, I started modeling. And then in the fall, so at the same time, I ended up, the lab I was in ran out of funding. And so they weren't able to renew my contract. And so I ended up, on just doing science advocacy full time until now, where I've just taken this new position at UCSF. But at that time, I had time to actually enter the X Prize, which is this nonprofit corporation that puts out these big prizes to try to solve these giant problems. And so one of them was pandemic modeling. So I put a team in the X Prize with a friend who's also at MIT in a neuroscience lab. And we created this hybrid epi model. And mine ended up actually being the top model for the US. And I'm just kind of showing you guys here some of the top models versus the actual cases, which are in blue for that time period that we modeled it. And I also met a bunch of other teams. So JSI versus COVID is a team from Slovenia. So Nina Rasic, who's also a PathCheck host, is one of the key people on that team. And PathCheck itself, you can see these are the top 10 models, but there were actually 104 teams of scientists around the world that entered this contest. And so that's how I met PathCheck. PathCheck is a nonprofit MIT spinoff. So it's funny that I wouldn't have met them anyway, which is like across the street from where I was at MIT anyway. But I did meet them through the X Prize, and they said, we have this Slack, come join us. And so PathCheck was started by Professor Ramesh Raskar, who's at the MIT Media Lab. And so it's this giant international Slack full of volunteers that have been working tirelessly to try to do something about a variety of issues in the pandemic. So that is how I got involved with PathCheck, and I'm now head of research there, along with a bunch of other hats for their new Epi Institute.
Cool. Could you maybe walk us through some of the data that you have worked on and show us kind of some of the tools you developed?
Yeah. So this was my model on the right, and so predictive models for cases. So this was actually pretty fun to put out there in the public, because we submitted it December 20th, and then it was like a horse race. So everybody had these models, and then as the cases came out, I don't know that I have a cursor to show you guys this, but as the cases come out, every day I would post like this many days till the model is gonna drop. And so I was predicting like by the end of March, we're gonna totally drop down, right? But then I had a big asterisk that said, unless a new variant or something else crazy happens, right? So my model was very accurate for 9 weeks untouched. So in yellow is my actual model, and then in blue were the actual cases. So this was like mid-December through middle of February. So there's different flavors of epidemiological modeling. So some are like classic epi models, some are more computer science, so that machine learning, and then there's a variety of other models. So mine was a hybrid model, and so was JSI versus COVID, which were those two out of the 3 top models were hybrid epi machine learning models. And it also one of the key features was that it took into account the Christmas and New Year's spike. So I was previously able to predict Thanksgiving spike. So I did the same thing. I sort of seeded every county in the country and was able to then predict the Christmas and New Year's spike. And let's see if I can go to the next slide. So one of the reasons that at PathCheck that we wanted this is we actually wanted to put these predictions on apps. So like in India, right? So this is just a map of India. This is one of our more recent predictive models. So we're able to predict which areas of India would have these big spikes next. And the reason this is important is because then you can do things with supply chain. You can get oxygen and medications to the right places. You can inform the public. You can make more rational decisions. If policymakers are open to that, which is always the if, right? But kind of the next thing. So this is not even. We're trying to get this onto a preprint server soon. But so this is what my model ended up doing about mid-February of 2021. It deviated, and so it didn't end up going all the way down. And this was originally because of the New York and UK variants. So you can see this big hotspot on the right, all the northeastern states. And at that same time was right when the New York variant, UK variant went up. So the model, even deviations in the model from the prediction is actually kind of useful information because it tells you, when variants are popping up that are actually escaping immunity, not being covered by vaccines. The new variants and vaccination and the fact that they're all like creating partial immunity makes predictive modeling challenging. So because epi models in general require extremely accurate data. So you need to know not just the reported cases, but the actual number of cases, which is less than the reported cases always because of problem that not everybody's being sequenced, right? And you have to know how immune people are. And, if these variants are partially escaping immunity, how immune people are is a really hard input for an epi model because you have to take into account each variant and each vaccine and how well it covers. And, there's like a bunch of missing data. So part of the modeling challenge is all this missing data. Oh yeah, this is just what I was saying. So if you look at just the northeastern states, they all deviate. And they all have this New York variant, which was escaping immunity. And then all the rest of the states went down, just like the model was predicting. So it really points to the fact that this is because of these variants. So this is in the New York variant going up over time here, and some of the other variants. So this is like in New York, you can see there's that switch right when the model deviates. So, this is the other thing I was going to say. So I think Serina is going to talk a little bit about this too, but there's these surveys now that are helping us get better estimates of actual case numbers. So, and earlier estimates. So we know that there's this big lag time between when cases are reported and when people actually get sick. So these Facebook surveys that maybe our audience has seen, they ask you if you have symptoms, if you know anyone's sick, they pop up. They're actually super helpful because they allow us to have a better idea of real case numbers than what are reported. And they also have this lead time. So in India, it's about 15 days earlier than reported cases that these Facebook surveys are able to tell us about case spikes, which allows us to then design early warning systems. So my newer model is trying to get around this variance and vaccination problem by just looking at early signals exclusively. So that's what we're doing now.
Yeah, you guys have a lot of cool predictors that you follow. Like you look at like what medicines people are searching for with like the 1mg and what foods they're searching for if they're looking for like soup and things like that. Like what are the other ways that you're trying to track people through their behaviors?
Yeah, so that's actually a cool paper I've been working on in collaboration with a online pharmaceutical company that only exists in India. It's called Tata 1mg, and people can go on there even for prescription drugs and order medications, search for medications. They can get their Tylenol and everything like that. So that company is one of the major distributors of medications. And so we know in this last wave with Delta in India, there was a shortage of medications and in particular areas. So Tata 1mg was partnering with us to try to see if we could do something about the supply chains. So they could have an earlier warning of where medicines need to go when, right? So we have a preprint on this, and we showed that there's these really robust with like R squareds of greater than 0.7 in Indian cities of what people are searching for, like things like flu medications and other things like that are early warnings for which cities are going to go up. So it's kind of cool because you can use it to predict cases, but you can also save lives by getting medications to the right places in time. So interestingly, in India, some of the top searches were actually for drugs that we should not be using, unfortunately, in COVID. So ivermectin and hydroxychloroquine and antibiotics, which are, it's bad to overuse those because that leads to antibiotic resistance. So that's kind of another interesting nugget to look at, how these medications are kind of improperly being used in the pandemic.
Yeah.
So.
Serina, I thought maybe you could talk to us a little bit about your model and how it can be used to sort of inform policy and COVID restrictions and reopening plans.
Yeah, sure. I think it'd be helpful for me to just start with an overall idea of what the model is before I get into some of the findings.
Cool.
Okay, so at a high level, what we have is we built a large-scale computational model that takes in huge amounts of near real-time mobility data to try to map the spread of COVID-19. And so this mobility data is anonymized, aggregated location data from cell phones, and we take it in the form that it can tell us at an hourly scale the movements of people from neighborhoods to specific points of interest. And so these are non-residential locations such as cafes, grocery stores, restaurants, gas stations, etc. And we have this for millions of points of interest across the US. And so our interest in this mobility data came from, of course, the insight that COVID, like other infectious diseases, spreads through human contact. And so if we want to understand how COVID is spreading, we want to be able to estimate where are these points of contact, where and when are people coming into contact, which communities are coming into contact, and how often. And so our idea is to use this data, this large-scale data, to estimate these real-life contact patterns. And so that's the idea of the model. And it takes in these hourly movements to then predict down to the individual hour and point of interest where the infections are happening. And so in this way, we're able to study both which places are the riskiest. And so we can ask, how risky is it to reopen restaurants entirely? How risky is it to go to a park, to go to a gas station? By looking at how many infections, according to the model, are happening at these types of places. So that's one type of analysis we can do. Since we're also looking at the movements of people from neighborhoods, then we can also ask which neighborhoods are more at risk. Do we see differences across neighborhoods in terms of mobility patterns during the pandemic? And what do those differences in mobility patterns then mean in terms of infection outcomes, in terms of cases, in terms of deaths. And so that's really the overarching idea of the model. And I'm happy to talk about some of the specific findings if
yeah, please.
Yeah. Cool.
Yeah, I'm really excited to look at it because I think it's got a very important data story there about disparity.
Yeah, totally. Would you be able to put up the figure 3 from the paper? Perfect, thank you. Okay, so there are 6 sub-figures here. Let me walk through it. This is the third figure from our Nature paper in which we introduced this model and talked about some of our findings. And so, okay, starting with subpanels A and B, what this is showing us is that we found that the model, even though we didn't give the model any demographic information about the neighborhoods, we only gave the model mobility information, the model was able to correctly replicate real-world disparities in infections. And so lower income neighborhoods were getting infected at higher rates, according to our model, and that's what you see from figure A. And communities that were less white were also getting infected at higher rates, according to our model. And so what this tells us is that these mobility networks, these hourly networks of where people are going at what times, they encode disparity in some way. And so then the question really is, how do these mobility data encode these kinds of disparities? What can we learn from mobility data that can actually inform the observed disparities that we already know about, that certain communities are getting infected at higher rates? What can mobility data tell us about the mechanisms that are causing these downstream disparities? And so then we took a really close look at the mobility networks, trying to figure out what the mechanisms were. And we found 2 main mechanisms. So the first one is shown in figure D. What that's showing you, and this is using the Chicago metro area as an example, it's showing you that lower income neighborhoods were not able to reduce their mobility as much at the beginning of the pandemic. And so you're looking at March 15th, you see that big drop. But the purple line, which indicates the neighborhoods in the bottom income decile, they remain above the neighborhoods in the top income decile. And this is from the first wave of the pandemic that we studied this, but in follow-up work, we saw that this was true in future waves as well. And so the first thing is that lower income neighborhoods were not able to reduce their mobility as much. And this was also true for less white neighborhoods when we looked at the top and bottom deciles when you measured them by the percentage of the neighborhood that had white residents. And so, from data alone, we don't know exactly why this is happening. This is observational, but of course we have theories about why this might be happening. For example, certain communities, like minority communities, lower income communities, are disproportionately represented in essential jobs, or they're in jobs that are harder to work from home. And so for all of these reasons, they were probably less able to reduce their mobility. So that's the first thing. The second finding, which you can see in the middle bottom figure, E, that's showing you that it's not only about how often you go out, but it also matters which places you're going to when you go out. And what we found was that even if you control for the type of place that people are going to, so you control for just grocery stores, the grocery stores that lower income people go to tend to be smaller and more crowded with longer visits than the grocery stores that higher income people would go to. And based on our model equations, we actually found on average that one trip to the grocery store was 2 times more dangerous in terms of risking infection compared when a lower income person went to the grocery store than when a higher income person went. And so what this figure is really showing you is on the bottom, on the x-axis, on the horizontal axis, we're showing you the risk to people from the top income decile, and on the y-axis, the vertical axis, we're showing the risk to the bottom income decile. And you can see most of those dots appear above the diagonal line, which tells you that most places are riskier to visit for lower income groups. And this result is also replicated if you look at, if you stratify based on percentage of white residents. And so this is really quite striking of a finding. I think it tells you that the ways in which mobility and inequality intersect, it's really quite nuanced. It's not just how much people are going out, but where they're going to, even when you control for the type of place that people are going to. And hopefully knowing about these mechanisms can then sort of inform the way that we reduce these disparities. So one thought that we had after realizing this was, on one hand, like it's really sad to see these inequalities appearing in the mobility data. On the other hand, there's a lot of things that are probably contributing to disparities, such as pre-existing health conditions or access to healthcare. And those kinds of things are harder to change in the short term. But because mobility is something that's changing every day, for example, I mean, if you look at figure D, you see how much mobility dropped at the beginning of March. Hopefully that means that there's also something that policy can do in the short term to try to mitigate these disparities.
And, obviously, that's what's so striking about the story here, because, the pandemic, I think, has obviously put racial and economical health disparities in high relief. And we've had like a ton of discussion on the matter.
Yeah.
But to see the evidence so clearly in something where you're not even searching for it, like, I wonder, what are your thoughts on, we know that we need to advocate for, our local governments and municipalities to use evidence-based rationale for their planning around the pandemic, but we've built a society based on the haves and the have-nots, and now we have this challenge to cover all these people who are typically marginalized and ignored, because the virus could care less about our divisions. And so we have the tools now, but how do we, as scientists, like, advocate for science-based policy solutions, do you think?
Yeah, it's a tough question. I think to start, of course, just asking these questions and taking these sort of data-driven approaches to try to understand where these disparities are coming from. For example, looking at mobility data like this, at least hopefully we can show with evidence that these things are widespread. And so, for example, here, this figure is using Chicago as an example, but we found that these findings held true. So that lower income and less white communities were not able to reduce their mobility as much, and that the places that they go to are riskier. This was true across all 10 of the metropolitan areas that we studied, which included among the 10 largest metropolitan areas in the United States. So it's widespread, it really is. And I think it's important to know just how sort of ingrained it is into our society, into the ways that our society functions, and that it's not so much an aspect of individual choice a lot of the time, but just reflects where you live and what kinds of places you have the opportunity to access. So I think having that sort of evidence to change the narrative a little bit is important. And then how do you actually get policymakers to listen? That's certainly a challenge. I mean, we've been working with policymakers. We've been lucky to actually in the last half year or so. So after the initial Nature paper came out, then we sort of pivoted to instead of just focusing on this very academic space, we pivoted to actually creating a tool that policymakers could use in their decision making. And how we did that was we partnered with the University of Virginia Biocomplexity Institute, and they had been advising the Virginia Department of Health for almost a year at this point. They already had relationships set up, and they thought that our model could be of use, especially around reopening policies. And so, as I mentioned, because our model looks at where people are going down to the specific point of interest, then you can actually use it to analyze which places are riskier, what would happen if you had, say, 50% of pre-pandemic mobility at a place or 80%, and you can run these hypothetical simulations to see, what if I had 50% mobility at restaurants, but then 75 at grocery stores and 100 at parks, and you can test all of these sort of heterogeneous, flexible policies to try to come up with the right trade-off between mobility and infections, which is a really difficult thing. And so that's really what we were working on in our follow-up work, building this as a tool that policymakers could use. And then finally, now we're still working with policymakers with the Virginia department, and they're thinking a lot about vaccines now. And this comes back to the inequality point, because we know that vaccines are not uniformly distributed across populations, and certain populations maybe trust the vaccine less or have less access to the vaccine. And so now we're working on data-driven solutions to actually encourage more populations to take the vaccine and just reduce those disparities there as well. So yeah, I don't, that's like a long way of saying, I don't know exactly how we can get policymakers to listen, but in my experience, after publishing our Nature paper, I was encouraged to see this sort of reaction by policymakers. We were invited to present our work to multiple municipalities, both state and city, and some international even. And they seemed to be citing the work when they were announcing their policies. And then we were able to build this very real relationship with the Virginia Department of Health, who we've been helping for several months now.
That's encouraging. Although I still am dubious about, I mean, everything around the pandemic has been highly politicized. So I still wonder about the motivation that people may or may not have to do the right thing. We've seen how resistant just the general public and therefore, the leaders of those constituencies have been to, everyone wants to appease everyone that wants to be able to do what they want and go get coffee when they want and have people do their nails when they want or whatever else. We're not really thinking about our fellow man, let alone people who are less fortunate than us or don't have the same privilege that we do. So I do worry that even though it's amazing and that's what we should be doing everywhere, that there's not going to be much motivation, or at least not motivation is going to exceed the motivators of capitalism, if that makes sense. But it's encouraging that people are reaching out to you. Like, that's awesome. Hopefully they'll take heed. But like, yeah. Christin, in light of like the current Delta wave, can you talk a little bit about, like, before you were, I know the data that you showed was, sort of in the earlier period, but as you've gone, you've said that you've noticed a little like periodicity and the infection waves, and like, what are your insights into how like the patterns of new variant emergence and like waning immunity complicate like the race to herd immunity?
Yeah, for sure. Well, just before that, I do have a comment about this disparities thing. I sent so many legislators emails about protections for essential workers. I think this is a big part of the story, is that, we made all of these people essential jobs without any protections, especially for high risk people, right? Like, there wasn't PPE in the beginning, and then there's nothing that says I sent out emails like, maybe we should lower the retirement age to 60 temporarily because people over 60 are so much higher risk, and we should allow them to stay home and with money and all of this. And it's kind of, I mean, this, I think the way essential workers have been thrown under the bus in this pandemic has just been awful, and of course that's related to disparities because it's, not Zoom jobs, not higher income jobs, right? So you end up seeing, the people that can't afford to stay home on their laptops, are being the ones that get hit the worst. So this is what I think. I mean, I think this plight of essential workers has been really awful. I don't know how to fix it. I think grassroots political work, I guess. I think that's the best tool we have at this point. Things like Merch for Science, people that are trying to get out there and spread the word, right, about this stuff.
Totally.
But anyway, the Delta wave, so there is periodicity. So I don't know if you've noticed this as well, Serina, but if you look at kind of how these waves are going, there's like a suspicious 6 to 8 between them. And so we know recently from a whole slew of papers that immunity, at least antibody immunity, starts to wane, and for around that 6-month mark. And we're seeing this in Israel right now too. We're seeing a whole new crop of infections, and not just infections, but also hospitalizations and deaths with Delta in Israel popping back up, and they're 78% vaccinated. So it's not just natural immunity that's waning, it's immunity from the vaccine that's waning at the 6 to 8 month mark, and it's sort of a steady decrease over time. And I think, this is part of why we're seeing the 6 to 8 months between these waves is, A, you have a new variant that, is partially escaping immunity, and B, you're seeing this decrease in immunity levels. So I think we can kind of expect this, unless we can somehow miraculously get the whole world Delta booster shots in the next 6 months. I think we're going to continue to see this pattern where new variants crop up and immunity wanes, and then we get another wave. So someone was asking me, in India, they just had this giant wave. So much so, like in Mumbai, 50% of the kids are coming back antibody positive. So they had infected at least 50% of the children. You can't see that in the data, this hidden pandemic, right? Because there's actually 25x cases as are being reported, but you can see it in the antibody data. And so, people were asking me this because everyone is trying to lock down now and thinking there's going to be an immediate another wave, and no, it's going to be 6 months from now. That's when it's going to happen, right? That's when they're currently, 50% of the population approximately, depending on where you are, there's some give or take, has antibodies, but antibodies to Delta. So they're pretty much protected at this point because they've burned through the population, right? So, yeah, I think that would be my very high level assessment of what's going to happen, is that boosters now would be better if they were boosters that were designed to Delta and to these immune escaping variants, but a third booster of just the regular one is going to help us somewhat, we've seen, but we should be factoring that into our models, I think, as well, like time since infection, time since vaccination.
Mm-hmm.
So
yeah, they are talking about, I think Biden is getting ready to approve boosters at the 6 month mark for all 3 vaccines very soon, which, side note, really sucks from a global equity perspective, because in places like Brazil and Africa, many other countries in Africa are still right around at 1% vaccinated. Mm-hmm. And the reason why we all need a booster is because we won't sit down somewhere and be still. And everyone took their masks off and they're going and partying. And the rest of the world hasn't gotten their first shot yet. Just saying.
Yep.
But Serina, how will you have to adjust the parameters for your model, for example, to account for the higher infectivity of Delta? Because now you have these points of interest, but you've got a viral load that's 1,000 times, what the previous strain was. Yeah.
So we do take a sort of machine learning approach to this, in the sense that we try to learn parameters from data. And we were actually able to show in our original work that we had very few free parameters. Sometimes machine learning models have thousands of parameters. We only had 3, and they were fixed over time. And so really what was surprising about the initial work was that our model was very simple, aside from this complex mobility data that we were using. And so we had this rich mobility network that showed the hourly movements of people from neighborhoods to places. And on top of that, we had basically 3 free parameters that were fixed over time. One of them represented transmissibility at home. And so we represented a sort of household transmission. Another one would scale the transmissibility at points of interest. And so at each point of interest, the way that our model worked was we would look at how many people who were visiting there at the same time, and then how large the area of that point of interest was, which we had in data. And so from that, we could compute the density of visitors. And we also knew on average how long people spent at that point of interest in minutes. And the idea is that, if you stay there for longer, it's a riskier visit. You have a larger likelihood of contracting the virus. And then we also looked at current rates of infectivity and susceptibility. And so in all of that formula, there was one parameter that was essentially a scaling factor that could scale how transmissible the virus was after you take into account these other factors like the size of the place, the number of people there, and how long they're spending there. And so to answer your question, what we're doing now is we're refitting the model on new data where we allow that scaling factor to change, where we allow it to be higher now. And so this works very well in theory. The challenge, though, like Christin was saying, is that the data is not that reliable. We're trying to fit to reported cases and reported deaths. And the situation is always changing in terms of how cases are getting undercounted. Reported cases will always be below the number of actual people infected. But how far below it is, and also for which populations it's below, that's always changing. So for example, vaccinated people, if they do have a breakthrough infection, we're certainly underestimating breakthrough infections because a lot of these breakthrough infections result in no symptoms or very few symptoms. If you're vaccinated, you're probably not really checking that much anymore and you're not getting tested. And so we're probably missing a lot of those. Or in certain areas, there's just less testing available. And so, yeah, it really is a challenge. We do the best that we can, and we report a lot of uncertainty as well in our estimates, so wide confidence intervals. But the answer is we try to fit to data, and fitting to data can be hard.
So I have a question for you both. We're all early career scientists, and we've all had an opportunity over the past year or so to be able to immediately use science for good in ways that we probably never imagined when we were planning our careers. But how do you guys feel about how the pandemic has changed your trajectory as a scientist? Christin, how do you see sort of your profession now and also your professional duty after this experience?
Yeah, I mean, it's been very interesting to me. I mean, I've always kind of been interested both in the science communication, advocacy, policy side, and the data science, bench science side, right? So it's kind of been a marriage of both of those things. I think it's changed my trajectory. For one thing, I was predominantly working on Alzheimer's disease, and now I've been working on COVID for the last year. So it's a little bit of a game change for me. But it's the same tools, different disease. So doesn't feel like a huge drastic thing for me. I think the thing that does feel bigger for me is just this idea of, well, first of all, that we have to get the science out quicker to people. How do you get science to the public in real time? Because the pandemic has been moving so quickly. And in the past, you have a year or 2 years to publish a paper, and you wait for peer review, and but right now we need high quality, reliable science, right, that gets to people in real time. In the beginning of the pandemic, people are saying to me, "Oh, is this peer reviewed?" It's like, well, the data's from 2 days ago, so no. It's gonna be a while. And I think, that's definitely true. In about 5 years, we're going to know everything there is to know about this pandemic, because the papers are finally going to be out there and peer reviewed, and it takes a while. But I think for me, I've been thinking about how do you get things out to the public in real time? And I think that if there was some sort of, like we have these preprint servers, well, there's two problems. First of all, you have to communicate in a way that people understand. So I think Neecey, I'm with Hood Medicine. You guys have started doing this, right, with the infographics, and a lot of people we know that are science communicators. That has been great. I mean, learning how to take what I do and turn it into a infographic that someone that's not a scientist could understand, I think is actually super valuable in terms of just how maybe we should be communicating science in general. Like, I think we're wrong to have things behind paywalls with jargon and with, I think if you can't put it in an infographic and explain it to the general public, maybe we're doing something wrong. Maybe we don't understand it well enough, right? So I think that's been great. I think we should do more of that. I think scientists should be explaining, the taxpayer dollars they use to the public. I think also with PackCheck, there's like a big computer science and app bent. So, we've been building apps, and I've been thinking a lot about, this intersection between, building things directly for the public based on our data analysis that we're doing in the lab, and how to bridge that, how to have things be more immediately impactful to get to people that they can use. So like Serina was talking about, risk and how different places are risky. So we're actually building a risk calculator right now for the public, right? That takes into account the variants, the vaccines, and all of this. And I've been thinking about this both as a public health intervention, but just being able to use our real-time data analysis to give back to the public something that they can use to put the power back in their hands and to make less risky choices, right? Whether that less risky choice is cutting down the risk by wearing a different mask or getting a vaccine or going to a restaurant in an off-peak time. So I think this could be helpful just generally, right? We know restaurants are risky. Maybe you don't need to, shut them down. But if you can drive traffic there with a risk calculator, to have people start eating their lunch at 2:30 p.m. instead of noon, these kind of things I think could be helpful in a number of regards. So this is the kind of thing that I've been contemplating, how to really bridge this gap between, scientists being in the lab, nobody knows what they're doing, and then when they say stuff or write stuff, nobody can follow it anyway. I mean, I think that's our fault. We should do better.
Yeah. What do you think, Serina? You're a little bit earlier than we are, but how has this experience changed you?
Yeah, I think so. Like I mentioned, I'm only going into the third year of my PhD, and we started doing this work at the end of my first year. And so I think I wasn't a very solid scientist before that. Like I didn't know exactly what I was going to do yet, and this has certainly shaped my direction, and I'm very excited by it. I think one thing that I've really learned a lot as a computer scientist is how we fit into this sort of interdisciplinary ecosystem where computer science can contribute to these sorts of things and where it can't. And so when we entered this space initially, we had been working on the mobility data for a while. We were doing a different project on the mobility data, basically a large-scale data science sort of project. And we pivoted because of this insight that I mentioned, which is that we understand that COVID moves through various infectious diseases, and people are coming into contact with one another. And mobility gives you a chance to try to estimate those places of contact. And so that's why we made this pivot. But as we were doing it, we were trying to stay very aware of, what can we contribute as opposed to epidemiologists who have been in this space for so long, or social scientists or public health experts. And so what we landed on was really focusing on this data science aspect, really focusing on the large scale population dynamics, trying to understand how these large mobility networks contribute to the spread of disease, as opposed to another project that might have been like, can we estimate exactly what R naught is or what R effective is? Or can we estimate exactly what the latency period is and stuff like that? We took that from literature and we tried to contribute where it was possible. And I hope I can take that forward as I continue on these sorts of computer science projects with some sort of societal impact. And so in particular, I think places that we've been able to contribute are around these logistical challenges, oftentimes trade-offs. And so I mentioned that a lot of governments have had to think about, on the one hand, the economy and economic activity and business closures and wanting to minimize damages to the economy. But on the other hand, wanting to minimize infections. And so as you reopen, as mobility increases at places, of course, infections have a risk of going up. And so using all of the data that we can to try to quantify those trade-offs. We all have some sort of intuition about them, but being able to quantify them and identify ways that you can be strategic about the trade-off, right? Because visits are not equally risky at every place. So can you return visits to just the right places that are less risky while also keeping perhaps higher restrictions at riskier places? And so using data to really quantify and inform those kinds of trade-offs. And then the final thing I want to say is I think I've also learned about the gap between academic work and actual tools that can be deployed into real use. And so this is why we had these two separate papers, the first one being largely scientific, being academic, which we published in Nature, and then the second one that turned the model into a tool that could be deployed and used by the Virginia Department of Health and other departments. And in doing so, we had to, think about a lot more real world features, like the detection rate changing over time. We had to fit the model to a lot more metropolitan areas in the right area, in the right jurisdiction for the government. And we had to build computational infrastructures that could allow us to actually run millions of model simulations in parallel efficiently. And then the most important thing was to come up with an actual front-end dashboard that could communicate thousands of findings in a quickly digestible way. And luckily, the department was able to give us feedback as we designed this interface. So I think there is a clear difference between the kind of work that is aimed towards a journal versus towards actual real-world impact. And hopefully in the future, maybe those things can come closer together, or scientists can try to do both, and we can have incentives in place that really reward that kind of work.
Yeah, I would like every science paper to come out with an infographic for the public as part of it, Like,
that would be a great
so
start.
Cool.
Yeah.
So before we get to the Q&A section, I'm going to do a quick hood minute cutaway so that we can kind of put everything in context and help our audience understand why we should think twice about going to that party. And this is with regards to why Delta is so contagious from, a microbiological perspective. But from a practical perspective, first of all, we tried to go back to normal too soon, whatever that means. Early in the pandemic, a lot of the data that we've seen today showed that we were kind of predicted to go for the infections to go down, but then they spiked, and then that trend just keeps happening because we are relying too heavily on vaccination and not really thinking about all of the other layers of protection that we have to put in place if we're going to really effectively reduce rate of infection. We don't enforce mask usage or social distancing uniformly anymore, almost anywhere. We don't have any travel restrictions in place right now, so people are just flying all over the place, mixing and mingling so that all of the variants can make new hybrids or whatever they want to do. And then there's Delta. It's twice as contagious as the Alpha original strain. Some of the features that make it so contagious is, first of all, it's got way more spike protein on its viral surface. So it has more opportunities to interact with the ACE2 receptors on your cells. And in fact, it has higher affinity for them. So that's one of the mutations. So it's able to find and stick to it better than other strains. That means it gets inside your cells easier because that is the lock that its key fits into. And then on top of all that, it's better at activating invasion of new cells by virus particles. So once it gets inside your cells and takes over your copy machine to make its own copies, and you start pumping out virus particles, it has a mutation that kind of helps prime new virus particles to, go out and infect new cells and new tissues. So that's a problem. And then there's the behavioral aspect coupled with the new advantages that the Delta strain has taken on. You become infectious sooner and you stay infectious longer. So they're estimating, you become infectious around like 3.5 days following exposure. And you stay infectious maybe 10 to 15 days longer than people did with the alpha strain. So, and it has a higher replication rate. So we're talking about people with over 1,200 times the viral load of the original strain. So people are out here, and we've taken our masks off. So you're out here spitting gas clouds of virus particles on each other. And that's really the problem. It's a perfect storm. We've got stalled vaccination progress, disinformation, so people aren't doing the right things, higher infectivity. People don't care. They're not using their masks. Everybody's having a great time. And so is COVID. So is Delta. And that's the biggest problem that we have here. So now we're going to get back to some of your questions, audience questions that we took ahead of time that we received a ton this week. And then we've got a couple good ones in the chat tonight too. So let's get into them. I think I'm going to swing this one maybe to Serina, but like for everybody watching, please do leave any other questions or comments you have in the chat and we'll try to answer them as we go. So Carol Messier says that she owns a restaurant and she had mentioned that there's, she, follows all of the recommendations with masking, et cetera. And she has, new HEPA filters, all that. But she's asking, what are the real risks of spreading the virus in the restaurant setting? So in your model, Serina, like what was the restaurant and sort of the tier of risky places?
Yeah. Okay, I'll start with the bad news first and then give the good news. So the bad news was we did find that restaurants were among some of the riskiest, but I'm going to caveat that by saying that, again, our model focused very much on mobility. And there are other factors of transmission that our model did not capture. And so maybe on average, based on mobility, the restaurants may come out on top because you have people in an indoor space sitting there for a long time, often up to an hour. And at least before social distancing was in place, you could be quite packed within a restaurant. But the good news is we also found that if you used reduced occupancy, which many restaurants are doing now, you get a lot of benefit quite quickly. And so for a small reduction in visits, you can get a large reduction in infections. And so we ran some simulations where we tested what would happen if you, for example, capped the maximum occupancy at 50% of the original maximum occupancy. So let's say you had a restaurant that could have 100 people before. Now it's only allowed to have up to 50 people. And this doesn't mean reducing visits by 50%. The restaurant might not always be at full occupancy. And so you're allowing visits to come back whenever it's not super busy and not super risky, but just capping it so that you don't totally hit the max. And what we found is maximum occupancy strategies were really effective. And so, for example, at 20% maximum occupancy, we saw, I think, a 40% reduction in visits, but an 80% reduction in infections. At, I think, 30% occupancy, we saw something like 30-60. So 30% reduction in visits and 60% reduction in infections. So you really get a lot of bang for your buck when you try to do this sort of strategic reduction. And the math behind that is that you're basically allowing visits to come back whenever things are not so risky, but reducing visits disproportionately at these high density periods. And so this is one way, mobility-based way, that we can stay reopened, but also relatively safe. And then in addition, of course, there's all these non-mobility ways as well, wearing masks when you're indoors, having filters, having dividers maybe between the tables. And so I've really been impressed by, I think, the ways that restaurants have stayed resilient and been able to stay open. And this is a great question.
Yeah, I mean,
there's all this takeout. Sorry, go ahead.
I was just going to say, so we've been talking to some restaurant owners in Cambridge, Massachusetts about the same thing, because I actually think, there could be a marriage of predictive modeling and restaurant owners because, this occupancy issue, if you just take the occupancy issue, like I hear, right, the problem with the occupancy issue is that the public, I think, does not know that at a different time, first of all, they'd be able to get a seat. They wouldn't be kicked out of the restaurant because it's over capacity, right?
Yeah, that too.
It would be so much less risky. So if you could somehow get that information, I think, restaurant owners, people that own establishments want to drive traffic at times that they don't normally have traffic, right? I mean, it's it's kind of like a win-win for everyone, to have people start places at times they normally wouldn't go. It's better for public health. It's also better for the restaurants because then they have customers at these times that's normally dead. I think this makes sense in general. I've never understood the rush hour thing, like why we're all trying to have a traffic jam at 9 a.m. and 5 a.m. I think we should be spreading this stuff out in general,
Yeah.
So I mean, basically, so I think there are ways to do it. Also, we need to look further into this air filtration because, even just opening a window decreases risk in schools by like 14x. I saw a post by YRD today on that, and the HEPA filters are even double that. So if we could also, first of all, figure out how much less risky it is if you have a better air filter or open windows, and then highlight that for the public. Hey, this establishment is doing this thing that is reducing your risk. Next, I think these kind of things they're not these sledgehammers like close down everything and, 20% of restaurants in Massachusetts went under in some of my favorite places, mom and pop.
I know, R.I.P. Coochie Coochie. Oh.
I think we recognize that is that's a real huge tragic loss, right? People's livelihoods, and do better in terms of being able to be more nuanced and have solutions that aren't shut it all down, but still do it safely. So.
Okay, our next question is from Melinda Gwynn, and she wants to know about the incubation period for Delta. How soon after exposure do we become infectious? What about the viral load? Pop quiz, we just went over it. When you become infectious right around 3.5 days, it's 2 days earlier than the alpha strain, and then it's about 10, 15 days longer. You're contagious after infection. And then the viral load, like I said, it's like 1,200 times that of previous strains. But these recent reports that I've seen published show that the viral load is pretty similar in vaccinated versus unvaccinated. We still have, pretty good, I think, predicted coverage. I think we've lost about 30%, they're estimating, in effectiveness of most of the vaccines towards Delta, but we still have, our T cell immunity, which is robust. And even with that loss, they still estimate there's good coverage in terms of keeping people out of hospitals or preventing death. Doesn't mean you won't have long COVID or some, discomfort, or depending when you're vaccinated, but it does mean that you can shed a lot of virus and infect a lot of people. And that's why, I think we need to caution feeling like we're invincible now that we're vaccinated. We're not. That's why they're trying to get us a booster. Like, we need to put our mask back on and continue being sensible, continue staying the course, and be disciplined enough to wait it out. So that's that on that. Our next question is from Annette Morales Reyes. And she asked, since it's believed that the Delta variant is more contagious, should social distancing be recommended or followed while outdoors too? That's a great question. Because of everything that we've said about the infectivity of Delta, the CDC has recently recommended that we reinstate like a social distance outdoors, and recommended, not strictly speaking, but it's saying that it's safer to have a mask on than not. I don't know why we just won't like mandate the mask thing. It's crazy to me, but I think you should be careful. I mean, I think we should not throw caution to the wind at all. We are in the thick of it. We are nowhere near the end because of our stubbornness. So there's no reason why you should take your mask off. Like, people are out here admitting they don't bathe regularly. Keep your mask on, promise you. Next question is from Nicole Malinoff, and she asked, is there any validity to ivermectin being used against COVID? My mom won't start talking about it. And as Christin has already shared with us tonight, that's unfortunate that so many people are, that people were searching for it in India. Here, we just had reports of people like going and clearing out shelves at pet stores. And this is all I need you to know about it. It's used for treating worms. The end. Do you know what I mean? There's no indicated use for COVID. Nobody's using it for COVID. It's not approved by the FDA for COVID. And even if it were, though, even if it were, how is that your answer? Well, they have ivermectin, so what? I'm still going to go to the concert. I'm still going to go to the ball game. I'm still going to not wear my mask in the grocery store because there's ivermectin. I guarantee you, if this was a worm plague, I don't think people would be like, I'm cool, I got my ivermectin. No, you would like try to prevent yourself from getting the worms, which is what it's used for. So please don't use it at all.
It's also have died from, you can't overdose on this stuff, so it is actually potentially harmful, and should be, at the very least, it should be prescribed by a doctor. So I mean, it's not something, if your doctor won't prescribe it, you probably shouldn't take it, right? I mean,
at all. And if it's not used for that pathogen, you shouldn't be doing it at all. And then Nicole also wants to know, what policy changes can we realistically expect to see with the recent FDA approval? I think it's probably easier from a regulatory standpoint to start mandating vaccines in certain industries. And we've seen a lot of businesses go ahead and start doing some of that, a lot of academic institutions. What about you, Serina? Does Stanford have a policy now on vaccination?
Yeah, vaccination is required for returning students on campus.
Yeah. So it's the sensible
thing to do.
And we're actually
also, if you're living on campus, we're required to do weekly testing as well. So vaccines as well as weekly testing.
Mm-hmm. That is appropriate. And I'm glad that an institution of higher learning, I mean, that's what's so crazy. It's like we're sending our kids back to school to learn science from people who refuse to wear masks. It's baffling. But next question is from Mike Parker. And he asks, what booster shots, type and when, are best for people who got the Johnson & Johnson vaccine? First, I'll say, if you got the Johnson & Johnson vaccine, you probably, I think at the time people thought, they're getting gypped because it's only one dose, or like it's not as effective or whatever. And it did have like, a lower efficacy than the others. But it actually seems to be, at least predicted to be effective against Delta and as much as any of the others. And so, like I mentioned, the effectiveness of vaccine in our vaccine, program, I suppose, fell to about 66%. But now that the CDC has officially started, talking about boosters, they've recommended it officially for immunocompromised people for sure. And like I said, Biden is contemplating making a third booster shot recommendation for people 6 months post, their previous vaccination. So it's definitely going to be something that's recommended for everyone, regardless of what vaccine you took. So you don't have to really worry necessarily about the specific vaccination that you took.
Well, I think they have not come out with the Johnson & Johnson yet in terms of what we're going to do. So I know September 20th, if it's been 8 months, you can get Moderna or Pfizer third boosters, but they have not come out yet with the recommendations for Johnson & Johnson.
Okay.
yeah, data on that yet or published the paper. So I think.
Yeah. I think. Yeah. I think they're just. I think the White House is just contemplating, like, even though it was recommended 8 months, the White House is contemplating just making it 6 months for everyone, just to make it easy, I guess. Christopher Brock Nelson. Wait, Christin, you're breaking up a little bit. And you're frozen.
I was just gonna say. Can you hear me now? Am I there?
Yes, no? I can hear you. Yeah.
Okay. I was just gonna say that interestingly, 1 million Americans have gone out and gotten a third booster just on their own.
Yeah.
So
totally.
These vaccinators, they're not like tracking them, right? Like you can just go in with say you haven't been vaccinated yet and just get a third booster. It's kind of unfortunate, but also kind of funny. Yeah. I mean, I kind of blame people because yeah. Anyway. So, yeah.
So the next question is, can you show the efficacy of masks and explain how the virus transfers from one infected person to another? And actually, I'm going to use an infographic from my favorite science advocates, and that's done by a science podcast, #superfan. And it's the same thing, I guess, as before. You know, you have surgical masks, which are effective. Even fabric masks are effective. I personally prefer to wear 2 masks, like 2 chains. I like to do a surgical mask underneath and then like a nice cloth one with a filter on top, taking no chances. But certainly you want to have one with a good filter. And even though this lovely infographic breaks down, the nitty gritty about, the levels of protection, I just want to implore everyone to return to wearing a mask, period, because it seems like we've all just given up on that part. And it's a very, very, very important last-ditch, final physical barrier for your face that you should really invest in committing to. So thank you, Christopher, for that question. Next is from Jennifer Fisher, and she asks, what should the new parameters be for someone who's in close contact for Delta? California Department of Public Health still uses within 6 feet for 15 minutes. And I think Serina's spoken to that a little bit this evening, about sort of like how we can try to use all of this information to inform policy, but I think it should be clear enough that with the viral load and with how lax we've become with masking and small gatherings, I mean, we don't even have, I don't know, a lot of places here don't even have social distancing in the restaurants anymore or anywhere. And no one really wears their masks anywhere. So start there, put your mask back on. And what do you think about like whether we should redefine what those close contacts are?
I don't actually, so I don't know if we should increase that distance for Delta or not. I mean, also it depends whether it's indoor or outdoor. So
yeah,
outdoor risk is 20x less than indoor risk. So I think if you're outside, that also makes a big difference. But whether you should increase it from 6 feet, I don't know. I think, I'm not sure. I think the 6
and by
feet
outside we mean like outside at the park, not outside at Lollapalooza. Let's be clear.
Right.
So, like, yeah.
Right.
Yeah.
Although Lollapalooza actually was quite encouraging, I think, because they had this giant gathering and I think you had to be vaccinated to go. So it was like all vaccinated people. And they only had 200 and some infections out of all the.
Were they all vaccinated?
Wow. They at least forged a card if they were.
Yeah.
But
yeah. I think with the increased viral load, I mean, I think 6 feet and 15 minutes were always sort of not arbitrary, but I think, you got to set the boundary somewhere. But in general, it's just the further apart you are, the lower the risk is, and the shorter you stay in contact, the lower the risk is. I did see somewhere that like 15 minutes with the original virus is something akin to 1 second with the Delta variant in terms of just because the viral load is so much higher. And so I don't know what the new magic number should be, but maybe lower than 15.
Yeah. What you guys?
Yeah, go ahead.
Oh, sorry, go ahead.
Oh, I was going to say 6 feet also, I think, maybe is something to take into consideration outdoors. Indoors, it's more about like, are you breathing the same air? And so regardless of how far apart you are from each other, if you're in an enclosed space for some time, doesn't really matter if there's not really a filter. You're breathing the same air after some time.
Sure does it. Christin, weren't you guys looking at a parameter about that where I don't remember what it was now. It's like was it the risk calculator where you were calculating how close by you passed by someone on the street? Was that what it was?
Yeah, so we were part of the risk calculators. We were just trying to see in various activities how many people you pass within 6 feet of. We were using that 6 feet number. I think the 6 feet is more to do with how far, the droplets in your breath or like a cough would travel than how many virus particles are per droplet. So I think, this virus is not going to change the dynamics of our breathing and coughing, right? Mm-hmm. I think that where it does change it is, less, you can have less droplets and still end up with a case of symptomatic COVID, right? Then it takes less droplets to get there than it would before. So if this is like a range and like the 6 feet has to do with how many droplets on average per area of distance far, then that could change things. But I think the 6 feet in general is more to do with how far our breath travels. So I don't know. That's kind of I'm giving you my initial thoughts, but I'd have to dig further to fully examine that. But I kind of agree that I think it maybe should be less than 15 minutes, but the 6 feet can stay the same is my that is with this right now. But we can come back next time and give an update, read up.
Right. Jillian PN asks, why are there no good resources to get info about the risk of breakthrough infections? Well, we're working on some. A lot of, I think, orgs like Hood Medicine, Unbiased Science Pod, your local epidemiologists, Unambiguous Science, Dare Pandemic, and lots of others have amazing infographics to help you get your questions answered. But what I will say, like Serina said earlier, the reported cases are always going to be like far below like what the actual cases are. And I think certainly with breakthroughs, we don't maybe have a full handle on it because of how many people might be asymptomatic or might not go get tested if they don't feel that bad or get that sick. But of the 168 million people who've been vaccinated in the US, that's a pretty sweet number. The CDC has recorded about 10,000 cases that have ended in hospitalization or death. So these are 10,000 breakthrough cases out of 168 million that have been reported. And of those, 19% were fatal. So again, I think, we're still collecting the data on what's on the real world effectiveness of our vaccines at this point, coupled with our inability to like adhere to like the guidelines. But vaccines don't create a force field that prevents infection. If you're walking around with no mask, viral particles can still float into your open mouth. So You have to use the Swiss cheese model of protection and have multiple layers to account for all those holes. There's no one perfect thing. We have to mask and get vaccinated and stay away from each other and be sensible. And then next, there's a question from literally everyone in the chat who had questions about kids' vaccines and how we can best protect them in the classroom. And like I mentioned earlier, I think, Pfizer's been approved for teenagers, essentially 16 and up. And we have emergency use, approvals for children 12 years and up. And as far as the next age range from 5 to 11, I think the FDA just this week said that they hadn't seen the data yet. I think Pfizer and Moderna were asked to expand their clinical trials to include more children. They want to catch any rare, side effects or anything. And a lot of people, I think I had a chat from maybe Ian, a question from Ian in the chat rather, about why we can't just rush that through because we've already approved it for adults. And for the children, it's really about, the trials are really about safety for sure, but also about dosing, right? So we want to make sure, for smaller children, definitely the infants, 2 to 5-year-olds, infants included, those probably won't come through till the beginning of next year. But it's all about getting the right dose, and that's something you want them to take their time doing as well. So why they're in the class right now doesn't make sense, but protect your child. If we're seeing a lot of school districts and governments who aren't doing the right thing, they're not prioritizing the lives of our precious children. You need to prioritize your child. Make sure your child has a mask on, and try to do what you can to talk to your schools, etc. We have.
Also definitely, if you have any influence over your kid's school, windows open.
Yeah.
If there's a way to get money for that school district to invest in better air filtration, the HEPA filters. I know that is not possible in every school district, but it's going to keep the schools open. Even if everyone can chip in a little bit of money and try to get a better air filter for the school. If there's any teachers that are willing to be heroes and have class in the park, as long as it's nice, that would be good. Outdoor classes. Definitely masks. I think masks were expensive too. We should have been sending masks to parents for kids, high quality masks. I wish the government would do that. I wish they would send all Americans a KN95, right? How much would that cost versus how much it's costing the economy to have things closed? You could keep things open if you took all of these precautions, I think. So those would be my suggestions. But yeah, I don't think we're going to get emergency use for kids' vaccines until January at least of 2020.
Yeah. And then our last question is from Anne DeHerence, and she asks, is there any way to write or call public officials to encourage quicker review of kids under 12 through the EUA? Like we said, probably not, but the March for Science is calling for the implementation of mask mandates at the state level, and they could use your help. There's a campaign to call on your state's governor, or also separately at the CDC, to demand renewal and mask mandates, and to advocate for implementation statewide, especially considering that we've sent all of our unvaccinated children back to school. So if you'd like, join that movement. We got to get something. It's up to us. So in as much as we want to protect ourselves and our families and our communities, just like, all the scientists around the world are doing right now, every, average citizen needs to stand up and participate in the process. So That was amazing. I'm so excited you guys had a chance to come and share your science and your brilliance with us. So thank you. Um, Before you guys go, could you each tell us kind of how to follow you and then how people can support like your orgs and everything? Serina, I'll start with you.
Sure, thanks. Yeah, I mean, you can find me on Twitter at Serina Chang 5, just the spelling of my name plus 5. And otherwise, I post about my papers. I post about the various media around the tools that we're creating. And my website is also linked there.
Cool. And Christin, where can we find you online?
Yeah, so you can find me on Twitter at Dr. Glorioso. You can also follow me on LinkedIn. I post quite a bit on there. It's just my full name. You can find me. Also, my nonprofit has a Facebook page, so it's Academics for the Future of Science, all one big run-on. So you can find us on Facebook. It's run by early career scientists at MIT, so students and postdocs and other people posting stuff. So those are the best places to find me at the moment.
Cool. Well, thank you guys so much. Have a great night, and we'll talk soon. Thanks.
Thank you so much.
Thank you so much. This has been really great. Appreciate it.
See ya. So as science advocates, we should keep doing what we can to keep our communities protected and speaking up for businesses and organizations to keep their mask requirements for crowded indoor public spaces, for local governments to tie lifting public health measures to data such as vaccination and case rates, and most importantly, that our federal agencies like the CDC prioritize public health over politics. The data has a story to tell, and we'd be wise to listen. And before we go, we have talked a lot about strategies to influence our leaders to advocate for evidence-based policy, but if we've learned nothing from the pandemic, once again, I'll make another plea for the fact that it's all up to us, which is why I'm totally crushing on a new group of brilliant kids taking it upon themselves to get their classmates and community vaccinated. So check out this clip from Philly Teen Vax and go follow them everywhere and donate to these babies.
They're cute.
And what are you doing here today?
Get vaccinated.
Are you scared?
Yes.
I can answer that for them. Yes, they are. They scared as hell.
How many vaccines do you hope to distribute today?
So our pre-registration had over 280 signups, and then we're taking walk-ins as well.
I'm nervous because I don't like needles.
For the past few months, our CHOP community vaccination program has been partnering with community organizations to reach the community where they're at and bring vaccine close, especially in areas that have previously had poor access to the vaccine. So here the zoo has graciously agreed to partner with us for this event and host us on site to be able to give this vaccine and bring people from around Philadelphia and especially the local community in to be vaccinated.
And what would you say to a teenager who's kind of worried about it?
I would say, number one, needles are not fearful. Like, you shouldn't be scared of them. And number two, like, if anything, you should get it to help your friends and family around you so they don't contract COVID. And to keep yourself safe because you want to be safe when you go back to school.
So did you just get the vaccine?
Yes.
How was it?
At first, it hurted a little bit, like a little pinch. But, you know, I had to fight through it and be like a man.
Definitely a relief to know that my son is about to encounter a bunch of different people, going to a new school, things like that. And, you know, some children don't keep a mask on, so at least, you know, and having underlying illnesses, it makes you feel more comfortable.
What would you say to a teen who's kind of maybe on the fence about getting vaccinated?
That every now and then you have to take a chance to do something that could possibly help anybody else around you, your community, and yourself.
I love it. So good night, everybody. We'll see you next week with the ladies from Unbiased Science podcast. Have a great night.